Hi everyone, a very good evening to all of you. Good evening to everybody. So, welcome back on the Dams Daily YouTube channel. And from today, we are starting the INICET Predictor series, right? And we would be doing the similar predictor series for NEET PG and FMGE exams as well. And yes, our purpose is to tell you the most probable topics that are likely to be asked in the upcoming exams, and as well as revise those topics for you. And just to let everyone know, the test for the predictor series is uploaded a night before in the daily quiz section on eMedicoz app. It is free for all. So has everyone given the test? Yes or no? No, you don't need to make the notes. We will provide the PDF of this, right, on the DAMS Telegram channel. So you can all join the official Telegram channel for DAMS, and then we would be providing you with the the PDF of this session there itself, right? So everyone, yes, did you give? So how was the paper? No, this live is only on the YouTube, right? So how was the paper for everyone? So if you realize the current pattern of almost all exams is very similar, right? The questions are not unique. The topics are not unique. They are routinely asked questions, but yes, the options are the tricky ones, right? So we will try and dissect. There are some clinical questions, some one-liners, and INICET again is going to ask you both. Recently, INICET has been asking quite a lot of factual questions as well. So do not ignore anything. Anything can be asked, right? So it could be a mix of factual and clinical vignettes as well. Okay, so are we all ready to go? Yes, perfect. So I'm happy and I will try and make it as productive as possible for all of you. Okay. Chalo, are you ready for the first question? Right, so the first question is, a woman on tamoxifen presents with postmenopausal bleeding, right? What is the investigation of choice for her, right? So what is the answer to this question, everyone? We need to answer in the chat box as well, and then I will keep telling you more about it. So what is the answer? So what is the answer? Yes, absolutely right. The answer is endometrial biopsy. Yes, so please remember, when we say postmenopausal bleeding, definitions are very important. A recent trend I've seen is that even definitions are being asked in both INICET and NEET PG, right? So this is bleeding after 12 months of amenorrhea, right? So bleeding after 12 months of amenorrhea will be taken as postmenopausal bleeding. And when we talk about postmenopausal bleeding, we all know that in case we ask you what is next step, we could mark transvaginal ultrasound, right? In fact, the guidelines say that even endometrial biopsy can be the next step, but typically, because TVS is easily available, less expensive, non-invasive, it is usually the next step, so transvaginal ultrasound. But when we talk about investigation of choice, what is the answer? It is endometrial biopsy, right? And most of the times this endometrial biopsy is a office endometrial biopsy. Can you all tell me what do we mean by office endometrial biopsy? It means it is done in the OPD, right? Now, what are the other important questions that you should know? So are you all ready for the other important questions, which are either PYQs or they could be asked as probable questions? So my first question to you is, you have to be ready and rapid fire in the chat box. My first question is, on transvaginal ultrasound, what endometrial thickness? Okay, so what endometrial thickness in general in postmenopausal bleeding is an indication to go for biopsy? Can you tell me what is the answer? What is the endometrial thickness which is an indication to follow it up with biopsy? So you have to be very clear. It has to be more than 4 mm. So please remember, up to 4 mm, we consider it as most likely benign causes, okay? But if it is more than 4 mm, then yes, a biopsy has to be done. Very good. My next question to you is, when we talk about endometrial biopsy, can you tell me what device do we use in India to take this biopsy? So remember, as far as India is concerned, very often we use a Carman's cannula. So when you do use a common cannula, we typically call it as EAC, endometrial aspiration cytology, right? So it is endometrial aspiration cytology. But I want to know from you, what is the special devices that can be used for this purpose? Excellent, very good. So I already see the answers in the chat box. So you have to remember two devices. One is called as a Pipel and the other is called as a Vabra aspirator. So they are special devices which are again used for endometrial aspiration cytology. Are you ready for question number 3? Okay, can you tell me what is overall the most common cause of postmenopausal bleeding? Now, data are different in different places, but the safest answer will remain as atrophy, right? So, when you say atrophy, it would include endometrial atrophy as well as vaginal atrophy, because both can cause postmenopausal bleeding, right? And some of these studies also show that polyp is, yes, an important cause, but this is a finding just in these studies. So we do not have overall data, so it is safest to go with atrophy. But other important causes are polyp and hyperplasia. Okay, my next important question is, this is a very old PYQ and in case it gets repeated, this is what you should answer. Can you tell me what will you answer if we say most common cause of PMB, especially if they mention in India? Although it is a very old MCQ, it's an old PYQ, but it can repeat. So if specified in India, it is safer to mark CA cervix. Okay, it is safer to mark CA cervix. If they are specifying in India, it is an older MCQ and that used to be the answer. So we will stick to it in case they repeat. Okay. All right. My next question to you is, suppose the woman is on tamoxifen, okay, for whatever reason, and she wants to conceive. Okay. For what is the minimum time for which tamoxifen should be stopped before she conceives or before she tries to conceive? What is the answer? So when should it be stopped before she tries to conceive? What is the answer? Yes, the answer is going to be 3 months. Okay, the answer is going to be 3 months. My next question to you is, when we talk about tamoxifen, okay, we all know that it is a risk factor for endometrial cancer. So suppose your patient is on tamoxifen, she has postmenopausal bleeding, you do an endometrial biopsy and the biopsy comes as hyperplasia. What would be your management? Can you tell me what would be your management? So patient on tamoxifen, she had postmenopausal bleeding, you did a biopsy, it turns out to be hyperplasia. What would be the management? So the typical answer, in case she has a PMB, she is on tamoxifen, she has hyperplasia, what should be the answer? The answer is going to be hysterectomy. Okay, so we are going to go and mark hysterectomy. Is that okay? All right. Please remember, raloxifene does not cause endometrial cancer, so it's typically tamoxifen. Yes. Now, I want to ask you, when we talk about endometrial cancers, a typical area that does tend to come in INICET exams is risk factors. So can you tell me which genetic syndromes are risk factors? Who is going to tell me which genetic syndromes are risk factors for endometrial cancer? So no, even if it is without atypia, right? So if it is associated with tamoxifen, you should answer it as hysterectomy, especially if your patient is postmenopausal. Okay. Yes, so you should definitely remember Lynch syndrome or HNPCC, right? Apart from that, remember BRCA1 and 2 mutations are also associated with endometrial cancer. PCOS definitely increases the risk of endometrial cancer, right? So we must remember, very, very important, yes, is also Cowden syndrome. Okay, apart from this, I want to ask you, which ovarian tumor, okay, so which ovarian tumor increases the risk of endometrial cancer? A very, very important MCQ. It has been coming in almost all exams. What is the answer? So you should typically answer it as granulosa cell tumor. And this is why, please remember, if a woman has granulosa cell tumor and we ask you which other investigation she should undergo, what will you answer? So if she has a granulosa cell tumor, which other investigation she should undergo? You should answer it as an endometrial biopsy. So patient can have simultaneously both the cancers, ovarian cancer as well as the endometrial cancer. Is that important? Clear? Lastly, what I want you to know is protective factors for endometrial cancer. Anyone, what are protective factors? So remember, oral contraceptive pills are protective. Okay, multiparity is protective. Okay, multiparity. Breastfeeding. Okay, breastfeeding is protective, and physical activity is also protective. On the other hand, please remember, nulliparity and infertility are important risk factors for both endometrial and ovarian cancers. Okay, so nulliparity and infertility both are important risk factors for endometrial, but I am saying also for ovarian cancer, and INICET keeps on asking this. Okay, perfect. Yes, that is what I was waiting for. Remember about smoking. Smoking is definitely protective for endometrial cancer. Now, I want to ask you, for which ovarian cancer smoking is a risk factor? For which ovarian cancer smoking is a risk factor? So, when we talk about smoking, it has been typically linked to which ovarian cancers? Mucinous. Okay, so it has been linked to mucinous ovarian cancers. But as far as endometrial is concerned, smoking is protective. Okay, chalo, are we ready for the next question? Okay, let's go on to the next question. Yes, smoking is a risk factor for squamous cell cancer of the cervix. Please remember, as far as smoking is concerned, it is not linked to adenocarcinoma cervix. It is linked to, yes, it is linked to cervical cancer squamous. Similarly, vulval cancer, right? Recently, it was a question in INICET. So remember, smoking is also a risk factor for vulval cancer as well as cervical cancer. Okay, is that clear? Chalo. Ready for the next question? Okay, let's see what you are going to answer for this. So this is a 17-year-old girl. She has come with primary amenorrhea. She has no secondary sexual characters. The FSH level is high, right? Now, uterus is present and the karyotype is XY. What is the diagnosis? Yes, not a difficult question. We have done this multiple times and you are absolutely right. The answer is going to be Swyer syndrome. So what were the clinical hints when we say Swyer's? So please remember, Swyer's is a type of pure gonadal dysgenesis, also called as complete gonadal dysgenesis, right? And I want to ask you, when you say it is gonadal dysgenesis, is it hypergonadotropic hypogonadism or hypogonadotropic? Again, something that the INICET people are fond of asking. Tell me, is it hypergonadotropic or hypo? So whenever we say gonadal dysgenesis, it means gonads are not functioning. So there is no feedback inhibition, right? And therefore this is going to be hypergonadotropic hypogonadism. Yes? Okay. Now, because the gonads are non-functioning, this is why whenever we talk about gonadal dysgenesis, the secondary sexual characters are going to be absent. Okay. Now, therefore, can you tell me, when I say secondary sexual characters are going to be absent, it is important and applied information. Can you tell me what would be the Tanner staging of the breast? Who is going to tell me what stage would be breast when we talk about Tanner stage? So remember, it is going to be Tanner 1. Tanner 1 is what is pre-pubertal, whereas Tanner 2 onwards, it becomes pubertal. So it is going to be Tanner 1. No, Tanner 2 is pubertal. Okay. Next important thing, when you talk about gonadal dysgenesis, we all understand gonadal dysgenesis can be Turner's and it can be Swyer's. Now, what are the key important differences to understand that this question is Swyer's and not Turner's, although Turner's is not in the options itself. So please remember, in Swyer syndrome, the first important thing is presence of a Y chromosome. What is the second important thing? Normal stature. Whereas in Turner's, they are 45x, so the stature is short. Yes. And now who is going to tell me the third important difference? Gonadectomy. Right. So Swyer syndrome would need gonadectomy as soon as diagnosis is made. So now I want to ask you, when you talk about Swyer syndrome, there could be problems in the SRY gene. So please remember, in up to 20% of cases, there may be a mutation in the SRY region, whereas in remaining 80%, the SRY is normal. So when I say there can be mutations, can you tell me what is the best answer when you talk about mutations? Is an AIMS PYQ as well? What is the answer? Yes, we are going to go with point mutations, right? So we're going to go with point mutations, and you are exactly on point. Very nice. Now, why are we going to do a gonadectomy? Because there is a Y chromosome and there is a female phenotype. So when we talk about Y chromosome and female phenotype, there can be gonadal tumors. So can you tell me which is the most common gonadal tumor that you will come across here? Right. So the most common gonadal tumor in gonadal dysgenesis, especially with Y chromosome. What is the answer? Yes, it is a very potential MCQ again. It is a gonadoblastoma. Very good. Well done. Okay. Yes, it is a gonadoblastoma. Perfect. Okay. Do you do a gonadectomy in Turner syndrome? No. Right. So those are the three important differences between Swyer's and Turner's that I want you to know. Who is going to tell me about the other options? So why is the answer not Kallmann syndrome? Because in Kallmann syndrome, the FSH levels are low. So it is typically hypogonadotropic hypogonadism. Yes. In this MCQ, we said the FSH levels are high. Second, what is the other important association when we talk about Kallmann's? Kallmann's has an association of anosmia. Yes, when you talk about a female having Kallmann syndrome, what would be the karyotype? It will be 46XX, not 46XY. Although Kallmann's can be seen in men as well, but in a female, the karyotype will be absolutely normal. And obviously, why is the answer not MRKH and not AIS? Because in both these, the uterus is going to be absent. And in both of these conditions, the FSH is going to be normal, right? So in MRKH, in AIS, the FSH is normal and the uterus is absent. Whereas in our MCQ, the uterus is present, right? And the FSH levels are high. Is that clear to everyone? Okay, please remember primary amenorrhea is a very important topic for INICET, and as I said, the definitions are being asked. So can you tell me by what age, if there is no menses, will you call it as primary amenorrhea? So please remember, when no details are mentioned, you are going to answer it as 15 years. If details are present, then we all know we take the cutoff as 15 years when secondary sexual characters are present. Can you tell me what would be the cutoff if secondary sexual characters are absent? So when secondary sexual characters are absent, then we will say the cutoff is 13 years, which means you will begin evaluation at 13 years. And can you tell me the third definition? The third definition is no menses within 3 years of 3 lark, right? So once a girl has had thelarch or breast development has started, she should have menses within 3 years. So this is the third definition. So you should know all these definitions, and yes, they are asked in the exams. Are we ready for the next question? Everyone good? I am seeing that everyone is answering nicely in the chat box. Good to go. Let's look at the next. I want to see if you have done this question correctly or not. So a woman is unable to conceive and she or the couple is undergoing evaluation. Is it right? Should we take her for evaluation? Yes. So this is very important. The couple has been trying for 1 year. Can you all appreciate this? Yes. So she has been trying for 1 year, and that is exactly why we say it is infertility. So please remember, when do you begin evaluation? You begin evaluation for infertility if the couple is not able to conceive even after trying for 1 year. Okay, so after trying for 1 year. But can you tell me what is the catch here? And INICET people can put that twist. What is the catch? Sometimes they will give you the age. So like in this, so if a woman is more than or equal to 35 years, we can begin evaluation even at 6 months. Okay, so then you can begin evaluation even for 6 months. Okay, now look at the question. The semen analysis of the partner shows azoospermia. So there is azoospermia. The FSH is elevated. We are asking you, what is the likely diagnosis? So yes, the answer here is Sertoli cell only syndrome. And to answer this question, it is not necessary that you should know about this syndrome. It could very well come with exclusion. So you are going to tell me, why is the answer, so why is the answer not obstructive azoospermia? Why is it not A? Because in obstructive azoospermia, the hormone levels are supposed to be normal, right? Whereas in this question, the FSH is actually written as elevated. Yes, is that clear to everyone? Okay, let's look at option C, hypogonadotropic hypogonadism. This is again incorrect. When we say hypogonadotropic, the FSH levels are supposed to be low. So this is again not the answer. Why not retrograde ejaculation? Retrograde ejaculation, again, the FSH levels are going to be absolutely normal. So by exclusion also, we should have been able to mark the answer as Sertoli cell only syndrome. Now please remember, what exactly is this? This is also called as Del Castillo syndrome. Okay, so this is also called as the Del Castillo syndrome. And what is the problem here? Here in the testes, you will see Sertoli cells. They are present, but what is absent? There are no germ cells. So if there are no germ cells, there will be no spermatogenesis. And this is why these men are going to have what? Azoospermia. Why is the FSH elevated? The FSH is raised in these because there is no inhibin B. Although please remember, yes, the inhibin B comes from the Sertoli cells, but here the Sertoli cells are not functioning normally because there is no interaction with the germ cells. So for the Sertoli cells to function normally, they should have interaction with the germ cells. So there is no inhibin B, and as a result of which the FSH levels are elevated. Is that clear to everyone? Yes, so no feedback inhibition. What about Leydig cells? The Leydig cells are usually present in this syndrome and they will secrete testosterone. So that is why the testosterone levels may also turn out to be normal. So despite normal testosterone, there is still azoospermia, right? So please remember, majority of times the Del Castillo syndrome or Sertoli only syndrome is because of idiopathic causes, right? But yes, sometimes there can be Y chromosome micro deletions. So sometimes there can be Y chromosome micro deletions. So now you are going to tell me, where is the SRY gene located? It's actually a locus, not a single gene, but where is it located? So remember, it is located on the, yes, short arm of Y chromosome. Yes, so it is located on the short arm of Y chromosome on the distal fragment. Yes, is that clear to everybody? Okay, perfect. Now, these men, obviously, because there is azoospermia, they will present to us with infertility. Okay, now who is going to tell me when we talk about obstructive and non-obstructive azoospermia? Okay, what is the next test to know which out of the two is the cause of azoospermia? So when you want to know about obstructive and non-obstructive ka difference, and we are asking you the next step, what should be the answer? The answer has to be hormonal assessment, and the single most important hormone has to be the FSH levels. Okay, in obstructive the FSH will be normal, whereas in non-obstructive, majority of times the FSH is raised. Can you tell me why in non-obstructive most commonly the FSH turns out to be raised? Because the most common cause of male infertility is primary hypogonadism, which means the problem is in the testes, and as a result of which there is no feedback inhibition, right? So that is why the FSH will be raised. But please remember, when we are asking you about the best test to differentiate between non-obstructive and obstructive azoospermia, then it is a testicular biopsy, right? It is not an initial test ever because it is invasive, and most of the times it is not required. But sometimes the FSH may not be able to differentiate, and then yes, the best test to differentiate between the two will be the testicular biopsy. Is that clear to everyone? Okay. Yes, FSH will be raised in all the conditions where the gonad is abnormal. So, whenever the gonad is non-functioning, the FSH levels will be raised. For example, can you tell me what would be the finding in Klinefelter syndrome? What would be the hormonal assessment in Klinefelter syndrome? So remember, Klinefelter's is 47XXY, and what is the problem here? The problem is that they have a small firm testes, and again it is going to be malfunctioning. So the spermatogenesis is defective here as well, and as a result these men also have what? Azoospermia, right? And in these conditions again the LH and FSH levels will be raised because the problem is in the testes. What will happen to the testosterone levels? They are going to be low. So in Klinefelter's, it is high LH, FSH and low testosterone. Who is going to tell me the key clinical finding in Klinefelter's? Because AIMS or INICET is now going to, sort of asking questions on this topic. What would be the clinical hint? Tall. Right, so these men tend to be taller, especially their arm and leg length. So the limbs are specifically tall. They are phenotypic males, but they would have what? Gynecomastia. Right, so they would have gynecomastia. The other keywords for you could be tremors, right? So tremors, low IQ, those could be the other keywords for you. So yes, you should remember them. Definitely they will have primary infertility because of azoospermia. The other key findings could be osteoporosis, cardiac problems. Okay, those could be the associated findings. Do they have autoimmune disorders? Yes. Okay, like Turner's, even in Klinefelter's, there can be autoimmune diseases. Which ones? So typically diabetes mellitus, Hashimoto's, but which are the other two? SLE and rheumatoid arthritis. Please remember, SLE and RA are typically not seen in Turner's. They are seen in Klinefelter's syndrome. Yes, everyone, good to go? Let's look at the next question. So this is a 27-year-old woman who has come to us with lower abdominal pain. There is spotting and there is history of amenorrhea. So identify the triad. The triad is pain, amenorrhea and bleeding with early pregnancy. So this patient is in early pregnancy and has come to us with pain, amenorrhea and bleeding. What are your DDs? So our DDs are either an ectopic pregnancy or abortion, which means one is intrauterine, the other is extrauterine. So now the question is asking us, which of the following support the diagnosis of ectopic? So let us look at the options. Is empty uterus on TBS suspicious of ectopic? Yes, it is something which is suggestive, not diagnostic. So we will take it as a true statement. Visualization of an adnexal mass, definitely. If we see an adnexal mass, this is the most important finding which tells us it could be ectopic. Can you tell me which kind of adnexal mass? It should be typically a complex adnexal mass, right? Okay. Presence of free fluid in pouch of Douglas. Yes, if you see free fluid with pain, amenorrhea, bleeding in the pouch of Douglas, then it could be a marker of what? It could be a marker of ruptured ectopic, right? Is it necessary that the patient will always be hemodynamically unstable? No. So even with ruptured ectopic, the patient can be hemodynamically stable if she comes to us early. This is exactly why we do what? Culdocentesis. So remember, culdocentesis is a test of ruptured ectopic, right? So it is a test of ruptured ectopic where you aspirate from the pouch of Douglas. Look at option 4. Presence of fetal cardiac activity in uterus. Is it correct? No, it is a false statement. If I see cardiac activity in uterus, I know I am looking at threatened abortion rather than ectopic pregnancy, right? So the question is, which of the following support the diagnosis for ectopic? So the answer will be 1, 2 and 3. Multiple completion type questions are characteristic of UPSC and INICET exams. You should include all options that seem correct. That is the idea. All that are true should be marked. Okay. Now, who is going to tell me where did we talk about colpotomy? Do we do colpotomy for ectopic pregnancy? So please remember, no. Colpotomy has nothing to do with ectopic. Colpotomy is done to drain a pelvic abscess. Okay. Then, which other investigation will not be useful? Should we do HSG? No. HSG should never be done if UPT is positive. So no role of HSG, no role of hysteroscopy. These are the other MCQs that INICET tends to ask. Which investigation is useful and which investigation is not useful? Okay, can you tell me what is the investigation of choice for ectopic? So when you talk about ectopic and I have to give only one answer, then we are going to stick to transvaginal ultrasound. But if it is a multiple completion type, then should I also include serial beta HCG? Yes, then we will also include serial HCG. The single best answer is TVS. Which is the gold standard investigation for ectopic? It is a diagnostic laparoscopy. Okay, so it is a diagnostic laparoscopy. Who is going to tell me about serum progesterone levels? Is it diagnostic? No, it is not diagnostic of ectopic. But can it be suggestive? Yes. So if we see low serum progesterone, how low levels? Less than 5 nanograms. So if we see low serum progesterones, then yes, it could be ectopic. But why is it not diagnostic? Because it could be ectopic, but this could also be an abortion. So serum progesterone doesn't help us differentiate between ectopic and an abortion. So it is not a confirmatory or a diagnostic test, but yes, it can raise the suspicion and help us in, evaluating the patients, but it is not routinely used because it cannot differentiate between the two. So these are all the investigations that you should know we do talk about in ectopic pregnancy. Are we all good to go? Please remember, progesterone levels which are more than 20 to 25 nanograms are usually suggestive of a live and a intrauterine pregnancy, right? Are we good to go? Okay, are we enjoying the discussions? Right, so let's go on to the next question. Which of the following are signs of impending eclampsia? Again, something that the INICET people are very fond of asking. Yes, so do we include epigastric pain? Yes. Do we include persistent pedal edema? No. It can be a finding, but it is not a criteria for impending eclampsia, right? Do we include headache? Yes. Do we include visual disturbances? Yes. So we are going to say 1, 3 and 4. So the answer is C. Well done. Now, please remember, whenever we talk about impending eclampsia, it is actually the premonitory symptoms of eclampsia, which means the treatment is going to be like eclampsia. So now, who is going to tell me what would be the treatment for a woman who has impending eclampsia? So you are definitely going to give Magself. This is actually the next step. In case they ask you next step, it should be Magself. Apart from this, you are going to give antihypertensives. Why do I need to add antihypertensives? Is Magself not an antihypertensive? No. So please remember, at therapeutic levels, okay, so at therapeutic levels, magnesium sulfate is not going to lower the blood pressure. And therefore, we have to add an antihypertensive. Can you tell me what would be the drug of choice here? Yes, it is going to be IV labetalol. Can you tell me why IV labetalol? Because majority of patients with impending eclampsia have a very high blood pressure, usually more than or equal to 160 by 110. So we will have to give it IV. So we will give Magself, we will give antihypertensives, and once we have stabilized the patient, we will do termination of pregnancy. Please remember, there is no role of conservative management. Okay, so there is no role of conservative management in impending eclampsia as well as eclampsia. So once you stabilize the patient, you have to deliver. Okay, now very important, you should also know when will you label the patient as pre-eclampsia with severe features. I am saying that I am seeing a trend towards questions coming on core definitions, so you should definitely know this. So when will you say it is preeclampsia with severe features? When my patient has a blood pressure of more than or equal to 160 by 110, and or it could be any of this, she has any evidence of end organ damage. So if there is any evidence of end organ damage, it is preeclampsia with severe features. Okay. Can you tell me when do you do termination of pregnancy if it is preeclampsia with severe? At and beyond 34 weeks. Okay. Who is going to tell me on what basis you will decide whether it is gestational hypertension or it is preeclampsia? So in preeclampsia, the patient should have proteinuria and or end organ damage. Whereas in gestational hypertension, there is no proteinuria, there is no end organ damage. Some students ask me, ma'am, then how will we decide whether it is preeclampsia or preeclampsia with severe features? Beta, it is same like saying, ma'am, whether it is hypertension or it is severe hypertension. It is a spectrum. So any time, okay, please remember, any time you see features of end organ damage, would you want to label your patient as only preeclampsia or preeclampsia with severe? Obviously, you will go with a better answer, which is preeclampsia with severe, because that tells you the urgency that you should have in managing the patient so that we as doctors can do the triage. Yes? Alright. So now you're going to tell me, when will you label the patient as chronic hypertension in pregnancy? So you will call the patient as chronic hypertension if she has high blood pressure in the first 20 weeks. Okay, so if she develops high blood pressure in the first 20 weeks, then it is chronic. Second, if my patient is a known case of hypertension prior to pregnancy. And third, if the BP remains high even after 12 weeks postpartum, right? So then you will label it as chronic hypertension in pregnancy. So as I said, you must know these definitions and you have to ensure that you don't do these basic questions wrong. Okay, are we ready for the next one? Let's go on to the next question. Okay, so which of the following physiological changes, okay, so which of the following physiological changes occur during normal pregnancy? Another topic that INICET is very fond of asking. So let's look at the options. So what is the first option? A decrease in systemic vascular resistance. Is it true? Yes. So peripheral vascular resistance is going to decrease. Increase in functional residual capacity. This is a false statement because residual capacity and the reserve volumes are going to fall. Okay. Decrease in plasma volume. This is also false because we will see a 40% expansion of blood volume or plasma volume. Will we see fasting hypoglycemia? This is true, right? Now, you have to tell me, so we know the answers. It is, what is the answer? The answer is 1 and 4. So, option C. Did you all get it correct? Okay. So, now you have to tell me, we see plasma volume expansion. What is the cause of plasma volume expansion in pregnancy? Who's going to tell me? The cause is number 1, estrogen, right? And the mechanism is it will cause upregulation of RAS, renin, angiotensin, aldosterone. So you also see high levels of aldosterone. Please remember, despite increase in blood volume, the resistance is going to decrease. Okay, the reason is estrogen and progesterone. They make the vessels resistant to vasopressors. So remember, progesterone and estrogen make the blood vessels resistant to vasopressors. This is why despite increase in RAS, the BP is going to fall. But if you have to mark one of these, out of progesterone and estrogen, which is responsible to make the vessels resistant, the single best answer will be progesterone. Why? Because progesterone is actually a smooth muscle relaxant, right? And that is why it provides the resistance. Okay, can you tell me what is the reason for fasting hypoglycemia? What is the reason for fasting hypoglycemia? The reason is raised insulin levels. So pregnancy is a condition where you will see hyperinsulinemia, right? So you will see hyperinsulinemia. So now you have to tell me what is the cause of hyperinsulinemia. It is insulin resistance. So in pregnancy there is insulin resistance. Which hormone is related to insulin resistance or responsible for insulin resistance? It is HPL. So HPL causes insulin resistance. So we will see fasting may hypoglycemia. Whereas, what would be findings in postprandial? Postprandial, there will be hyperglycemia, right? So, postprandial में hyperglycemia होगा. Quickly tell me, what happens to insulin resistance as POG increases? The insulin resistance will also increase, which means the insulin levels will also increase as POG increases. Okay, my last question to you is, does this insulin, maternal insulin, does it cross placenta? The answer is no. So please remember, maternal insulin does not cross placenta. Then which hormone will be responsible for fetal growth? So it is not maternal insulin, it is the fetal insulin itself. So IGF-1 typically, insulin-like growth factors. If that is not in the options, you are going to go with fetal insulin, not maternal insulin. Okay, so please remember there is no role of growth hormone in fetal growth. Now, in a diabetic pregnancy, yes, we see macrosomia. Can you tell me the reason? So here you are going to answer it as hyperglycemia. Why? Although insulin cannot cross, but glucose can cross. So glucose crosses placenta. This maternal hyperglycemia will cause hyperglycemia in the baby. Yes, so it will cause hyperglycemia in the fetus, which will cause the release of insulin, which will cause the growth. Okay, quickly tell me, there is no doubt that as far as the fetus is concerned, we see hyperglycemia. But if they ask you newborn baby of a diabetic mother, what will you find? Newborn baby of a diabetic mother. Will you see hyperglycemia or hypoglycemia? So now the glucose supply has stopped. So remember, now the answer will be hypoglycemia. So when they ask you about the newborn baby, it is going to be hypoglycemia. Well done. Chalo, आगे बढ़ते हैं. So which of the following is a contraindication to vacuum assisted vaginal delivery? So did you do this one right? So nowadays again you will get questions on instrumental delivery, so you need to be sure. Please remember, prolonged second stage of labor is actually an indication to do instrumental delivery. Occipito transverse position, can we really do a vacuum? Yes. So this is a condition like a deep transverse arrest. Please remember, when there is a deep transverse arrest and the pelvis is normal, right, then yes, we can do instrumental delivery. And typically, which instrument do we use? We will use a vacuum. Can you tell me why? Because when you say deep transverse arrest, it means the arrest is high up at the level of the ischial spines, right? And usually at that high level, we don't apply outlet forceps, right? So the preferred instrument here is going to be vacuum. But please be very careful. Most of the times when we say deep transverse arrest, most common cause of DTA is actually abnormal pelvis. Which pelvis? Android pelvis. So if DTA is because of an abnormal pelvis, then the management will be cesarean. But still, it is not the answer here. Let's look at the other options. Non-reassuring FHR. Can we use instrumental delivery? Yes. Very, very important. If you come across fetal distress in the second stage of labor, which means the cervix is fully dilated. So if you come across fetal distress in the second stage of labor, this is actually an indication to do instrumental delivery, right? There is no doubt overall forceps is preferred over vacuum, but vacuum is not contraindicated. In fact, more commonly you will see vacuum only, right? So this is not the answer again. So which means the answer is option D. Why option D? Because you will not apply vacuum. So if we ask about contraindications of vacuum, we will not apply vacuum in prematurity. Especially it is absolutely contraindicated if the POG is less than 34 weeks. Okay. Now you have to tell me what are the other contraindications for vacuum. Can you tell me? So very, very important. Face presentation. You will not use a vacuum. Okay. Third, after coming head of breech. Again, we don't use vacuum here. Where else? Very, very important. If there is a big caput. So if there is a swelling of the scalp, you cannot apply vacuum. Please remember, in these four conditions, although vacuum is contraindicated, but in all these four conditions, forceps can be applied. So these are not contraindications for forceps, they are only contraindications for vacuum. When we talk in general as contraindication for instrumental delivery, it means it is a contraindication for both vacuum and forceps. Can you tell me what would be the answer here? So very simple, wherever vaginal delivery is not possible. For example, mentoposterior will be a contraindication for both. Brow, transverse lie, these are all very basic questions, right? So in all these conditions, you can't do a vaginal delivery. Cephalopelvic disproportion, a contracted pelvis, right? Then HIV positive, we will usually avoid doing an instrumental delivery. Then if the baby has certain problems like osteogenesis imperfecta, or the baby has a coagulopathy, then in these conditions both instruments are going to be contraindicated. So remember concepts, wherever you cannot do vaginal delivery, obviously you will not do instrumental delivery. Okay, are we all good to go? Chalo. Again, all exams are currently asking something or the other about engaging diameters, and you have to ensure that you don't do these topics wrong. So which engaging diameter is not correctly matched? Again, a typical method of INICET exams, match the following, okay, true and false. They are all INICET type questions. So what is going to be the answer? So mento, vertical and brow, is it correct? Yes, the value is 14 centimeters. It is also the longest fetal head diameter. Okay, submentobregmatic, is it face? Yes, this is also true. Submentobregmatic, what is the value? 9.5, and the head would be in full extension. What about brow? Brow is partial extension. Okay, it is in partial extension. Deflexed head. Yes, the answer is occipitomental. No. So this is the answer here. This is a false statement, because when the head is deflexed, what is the answer? The answer has to be occipitofrontal diameter, which measures around 11.5. If they say partially deflexed, right, then what would be the answer? So if we say partially deflexed, then the answer will be suboccipitofrontal, right? Similarly, when they say deflexed and occipitofrontal is not in the options, you go with suboccipitofrontal, which measures around 10.5. I also want to ask you, if the head is deflexed, which fontanelle will you feel on PV exam? Can you tell me? If the head is deflexed, which fontanelle will you feel on PV exam? So remember, it will be the anterior fontanelle, right? How do you identify its anterior? It will be rhomboid or diamond shaped. Yes? Okay. Now look at the option, last option, well flexed head. Is it suboccipitobregmatic? Yes, this is again a true statement. It measures 9.5. Please remember, when the head is well flexed, which fontanelle will you feel? Yes, in this case, it is going to be the posterior fontanelle, which is triangular in shape. Yes, which is triangular in shape. So these are very, very important. You should know these. And please remember, if we ask you what is the presentation when the head is well flexed, don't answer cephalic, answer it as vertex. Okay, so answer it as vertex. So you should know these engaging diameters. Apart from this, remember, when we say occipitoposterior or right occipitoposterior, the pelvis will be android. When we say persistent OP or direct OP, then the pelvis will be anthropoid. Okay, when we say face presentation or brow presentation, the pelvis will be platypaloid. Okay, deep transverse arrest, I have told you the best answer is android followed by anthropoid. Okay, so these are the other related questions that they ask from this topic. Are we ready for the next question? Okay, let's go on to the next one. Which of these is not? Did you all read the not? Because you have to read the question carefully. There was a not in the MCQ. Which of these is not a test of Down syndrome in the first trimester? So if you read it carefully, then it becomes easy. So we all know that triple test is a test of second trimester. Come on, tell me, what are the components of triple test? So this includes HCG, alpha fetoprotein and UE3. It does not include inhibin A. Inhibin A is typically included in which one? Quadruple test, okay, or the quad test. Right, the other relevant question is, what are the other names for triple test? It is also called as a BART test and a Kettering test. When do you do it? So both triple and quadruple tests can be done between 15 to 22 weeks. So whether we ask you about the quad or the triple, it is 15 to 22. Very good. Okay, combined test, we all know can be or is a test of first trimester. Who is going to tell me what are the components of combined test? So number one, it is the dual test, and number two, it is nuchal translucency. What are the components of the dual test? HCG and PAP-A. When do we do the combined test? So the combined test is done between 11 to 13 weeks. I'm sure you all know, but I'm just going to reinforce. HCG levels are high and PAP-A levels are low. What about alpha fetoprotein and UE3? So HCG levels are high, alpha fetoprotein and UE3 are low, and inhibin A is again raised. Very good, excellent. Okay, NIPT is very, very probable to be asked this time in the exams. Remember, it is called as cell-free fetal DNA test. Right, so it is called as cell-free fetal DNA test. Can you tell me which or whose blood sample are you taking? You are going to take the maternal blood sample. The test is usually done beyond 10 weeks. Remember, it is not a diagnostic test, but yes, among all screening tests, this is the best screening test because it has a very high sensitivity value. Okay, so it is the best screening test for Down syndrome. Remember, it does not give us the full karyotype. Okay, so full karyotype nahi milta. It will only tell us about some karyotypic abnormalities like trisomy 13, 18, 21, monosomy X. These are the ones that we usually get to know about. What is the source of this fetal DNA? It is placental cells apoptosis. Okay, so apoptosis of the placental cells. NT has been a constant question. So who is going to tell me what is the ideal time for NT? Yes, NIPT, yes, is used as secondary screening, not as primary screening, because it is very, very expensive. Right, so NT, the ideal time is 11 to 13 plus 6. And if the NT value turns out to be more than or equal to 3 mm, it is considered as increased NT. Okay, increased. Can you tell me what would be the next step if the NT is increased? So if NT is increased, the next step should be answered as chorionic villus sampling, which can be done anywhere from 10 to 13 weeks. Don't answer it as amnio, because amnio is a test of second trimester, usually done after 15 weeks. In modern times, we don't really do early amniocentesis, right? So, which is usually done between 11 to 14. So, we do have a question on it and we will look at the next question. Are you ready? Are you with me, everyone? Okay, perfect. So, this is again something that INICET is fond of asking, the procedures and their POGs. So which of the following is not correctly matched? So early onset preeclampsia, is it less than 34 weeks? Yes. So if you diagnose preeclampsia before 34, it is early. After 34, it is late. Early amniocentesis, this is what is incorrect. I told you this is done between 11 to 14 weeks, right? Growth scan, yes, done between 28 to 32 weeks. The single best answer will be around 32 weeks. Termination of pregnancy if it is a well-controlled diabetes. So it doesn't matter whether it is controlled on insulin or diet. If it is well controlled, the timing should be 39 weeks. But yes, we can go up to 40 weeks. If it is well controlled, do not terminate before 39. Okay, so do not terminate before 39 weeks. All right, can you also tell me, when we talk about early onset preeclampsia, which is the predictor test that we use? So we are doing the predictor series. So can you tell me which test is done for prediction of early onset preeclampsia? Who's going to tell me? Yes, it is a uterine artery Doppler, right? Typically we will do it very early, which is around 11 to 13 weeks. Okay, and please remember, okay, please remember, when we talk about uterine artery Doppler, the single most important parameter that we study here is PI, pulsatility index. Okay. Can you tell me where else do we use uterine artery Doppler apart from this? So uterine artery Doppler apart from this is also used now for diagnosis of IUGR. Okay, similarly, even umbilical artery Doppler is used for diagnosis of IUGR. Again, for diagnosis of IUGR, what we study in these vessels is what? It is pulsatility index. And what is the cutoff to say it is IUGR? The PI should be more than 95th percentile. Okay, so the pulsatility index should be more than 95th percentile. Okay, and I'm sure you know the other definitions of IUGR. So we definitely take AC less than the 10th percentile, right? Or estimated birth weight less than the 10th percentile. If it is less than the 10th percentile, then we need to do additional testing for diagnosis like Doppler studies. Whereas if abdominal circumference or estimated birth weight are less than the 3rd percentile, we will straight away say it is IUGR. You don't really need to now do Doppler to make the diagnosis. Is that clear to everyone? Okay. So these are some of the most important timelines that have been asked and can be asked again and again in your exams. Okay, but some very basic questions. What is the timeline for level 2 ultrasound? 18 to 22 weeks. What about fetal echo? Again, 18 to 22 weeks. What about gestational age assessment? So gestational age assessment is best done in the first trimester using crown rump length, typically done between 7 to 9 weeks. If you want to know about viability, then this is again a first trimester ultrasound, right? We are going to look for cardiac activity. So you should know these timelines for different things that we might be doing. What about PUBS? What is PUBS? Percutaneous umbilical blood sampling, which is the other name for chordocentesis. When do you do it? So this should be done at and beyond 18 weeks. Okay, at and beyond 18 weeks. You might want to do it in which? RH negative pregnancy, right? Chalo. Let's look at the next question. Which complication? The key word here is specific to monochorionic twins. What is the answer? That is an easy one. I'm sure you've done correct. Yes, it is twin transfusion syndrome, right? So this will be seen in which type of twins is my next question, MCDA or MCMA? So this will be seen in MCDA. Okay, MCMA is actually protective. Now, what about others? IUGR, discordant growth, preterm labor. They are related to number of fetuses. More the number of fetus, the higher is the risk of IUGR, the higher is the risk of preterm labor as well as discordant growth, right? Please remember, which fetal complications are not seen in twin pregnancy? So I am asking you, which fetal complications are not seen in twin pregnancy? So then your answers should be either macrosomia or post-term pregnancy, depending on which one would you see in the option. So macrosomia and post-term. Now when we talk about monochorionic twins and we ask you specific complications, yes, you all know about twin-twin transfusion syndrome. What are the other specific complications? So one is called as TRAP, the other is called as TAPS, twin anemia polycythemia sequence. This is twin reversed arterial perfusion. Okay, then selective IUGR. So be careful of this term. Selective IUGR is a specific complication of monochorionic twins, right? So these are the specific ones. Then single fetal demise. Okay, when one of the twins might die and the other may survive. So single fetal demise, right? Now, can you tell me which is the specific complication of MA twins, monoamniotic twins? What is the specific complication? Right, so the specific complication here is cord entanglement. Okay, perfect. It is cord entanglement. How do you deliver MA twins? So remember, MA twins, which means no dividing membrane between the twins, right? So if it is MA twin, it is always delivered by cesarean, right? Always delivered by cesarean. But if it is monochorionic and diamniotic, or even if it is dichorionic and diamniotic, which means dividing membrane is present, then how will you decide the mode of delivery? Then you have to look at the first twin. Who is the first twin? The one which is closest to the internal os, right? So as long as the first twin is cephalic, we will do a vaginal delivery, right? If the first twin is non-cephalic, then we are going to do a cesarean section. Okay, remember, when there are any complications, so whether it is twin-twin transfusion or TRAP or TAPS, if there are these complications, especially the twin-twin transfusion and TRAP, they will also be delivered by cesarean section. Okay, so they will also be delivered by cesarean. Perfect, very good. Good to go? Chalo. Again, a very important topic that INICET is usually fond of asking, which drug is not correctly matched to its side effect? What is the answer here? So methyl ergometrine, does it cause hypertension? Absolutely yes, this is a true statement. Okay, carboprost, does it cause bronchospasm? Yes. Misoprostol, hyperthermia, that is also correct, which means yes, the answer is D. How many of you have done this one incorrect? Please remember, this is very important. Oliguria is not a side effect of Magsulf, right? But then you have to tell me, if it is not a side effect, why do we monitor urine output? Why do we monitor urine output? So we monitor urine output because the route of excretion of Magsulf is oliguria. So if your patient has oliguria, then toxicity can happen. And this is why, if my patient has oliguria, should we give Magsulf or not give? So do not give. Okay, then you have to not give mag sulf. Is that clear? And how will you define whether it is oliguria or not? So please remember, we would say oliguria is less than 30 ml per hour or less than 100 ml in 4 hours when we are doing the monitoring for mag sulf. Also please remember, serum magnesium levels are not routinely monitored. Okay, we don't routinely monitor them. Can you tell me when will you send magnesium levels? When you see signs of toxicity. So you will send magnesium levels if there are signs of toxicity. Come on, quickly tell me, what is the first sign of toxicity so that you can send magnesium levels? The first sign is going to be loss of DTR, deep reflexes, or loss of knee jerk or patellar reflex, right? So loss of patellar reflex, which comes at what levels? Around 10 milliequivalents. What are therapeutic levels? Yes, therapeutic is 4 to 7. है ना? So therapeutic is 4 to 7. Some textbooks say up to 8 as well, but the standard answer is 4 to 7. Very good. Let's look at important applications. So when you say methyl ergometrine causes hypertension, which means where is it contraindicated? It is contraindicated in pre-eclampsia, eclampsia and heart disease. When you say carboprost causes bronchospasm, it means it is contraindicated in asthma. Is misoprostol contraindicated in asthma? No, misoprostol causes bronchodilation. Okay, it causes bronchodilation. But yes, because we have to know, it can cause fever with chills in the postpartum patient. Okay. Also remember, misoprostol can cause hypotension. Okay, it can cause hypotension as well. What about oxytocin? So can you tell me, if you give IV bolus, what is the side effect? It will cause severe hypotension. Isliye never give oxytocin IV bolus. You will give it as a IV infusion, or you can give it intramuscular. Okay, good to go everyone? Chalo, let's move on to the next. So nowadays, yes, there is always likelihood of getting at least one question from placenta, especially in INICET. Let's look at the options. So which of these is not correct? Can you tell me what is the answer? So first I want to know how many of you have done this correctly. What is the answer? Right, the answer is option A itself. You have to tell me why is it A? What is wrong? It's a long statement, and INICET does this. They give you these longish statements, so you will take time and then you will decide whether it's true or false. Yes, it is definitely remodeling of spiral arteries. This part is true. But what is wrong here? The remodeling is not done by syncytiotrophoblast. It is done by which cells? So it is done by the extravillous endovascular cytotrophoblast. Yes, it is not done by the syncytiotrophoblast. Let's look at other options. Placenta succinctoriata can be associated with vasa previa. Is it true? Yes, it can be associated with vasa previa, and then it is called as vasa previa type 2. Can you tell me what is vasa previa type 1? So type 1 is when it is associated with velamentous placenta, right? So which is what is more common type of vasa previa? It is type 1. But please remember, in succinctoriata there is a accessory lobe, right, which is smaller in size. Can you tell me to which lobe is the cord attached? Is it attached to both the bigger and the smaller lobe, or only the bigger lobe? So the umbilical cord will be attached only to the bigger lobe, not to the smaller lobe. And this smaller lobe can be left behind and it can cause PPH. So succinctoriata can present as PPH. What will be the specific case scenario? They will say there is PPH, placenta is expelled, it looks complete, but still there is ultrasound is showing tissue inside the uterus. So placenta looks complete because this is an accessory lobe, and this is when you have to know they are talking about suction churiata, right? Let's look at option C. HCG is secreted by syncytiotrophoblast as early as 8 days. It's very important and it's a true statement. I want to know from you what type of hormone is HCG. Jaldi batao. It is a glycoprotein hormone synthesized by the placenta. Okay, remember it is the alpha subunit which is similar to LH, FSH, TSH. Can you tell me which is the single best answer if we ask you it is identical to what? LH. Remember the beta subunit is what is used in the pregnancy test. Also remember HCG is the first stimulus for what? For testosterone release from the fetal testes. And very, very important, HCG will maintain the corpus luteum of pregnancy. Right? Okay, let's look at option D. Umbilical artery resistance decreases as POG increases. Is this true? Yes. So, in a normal pregnancy, can you tell me what will happen to the SD ratio of umbilical artery? Anyone? Will it increase or will it decrease? The SD ratio will decrease, right? But what will happen if there is uteroplacental insufficiency? Then the SD ratio will increase. The pulsatility index will increase. The resistive index will increase, right? So remember this. So this is why one of the other parameters we study in these Dopplers is SD ratio. Okay, so good to go everybody. When would you do a termination in absent end diastolic flow? At and beyond 34 weeks. And when will you do termination in reversal of end diastolic flow? At around 32 weeks. Please remember, if they say you are seeing late decelerations or they say there is loss of beat to beat variability, then when will you do the termination? Then you have to do termination irrespective of POG. Okay, so then it has to be irrespective of POG. Very well done. Chalo, let's go on to the next question. Again, something that the INICET people are fond of asking, which teratogenic effect is not correctly paired? What is the answer? So, is option A correct? How many of you have marked answer as A? This is absolutely correct. Okay. DS causes clear cell cancer, which is a type of adenocarcinoma. Is that clear to everybody? Yes. So, in fact, it can also cause cancer of the cervix. Okay, so it can also cause CS cervix, diethylstilbestrol. But the single best answer is clear cell cancer of vagina. Parvovirus, does it cause hydrops fetalis? Yes. Which other infection is very characteristic for hydrops? It is syphilis. Right? So, syphilis will also cause hydrops. What about HIV? Does it cause hydrops? No. HIV will not cause hydrops fetalis. In fact, HIV is not teratogenic. Okay, so it is not teratogenic. Right. What about varicella? Does it cause limb defects? Yes. Apart from limb defects, it will also cause skin scarring. Okay. Can you tell me when would congenital varicella syndrome happen? When is the risk of congenital varicella syndrome risk highest? So, what POG? When she acquires infection between 13 to 20 weeks. Okay, so what about the answer? The answer is D, because isotretinoin, what does it do? Isotretinoin will classically cause microtia and anotia, not cataract. Cataract किसके लिए keyword होता है बेटा? Cataract is the keyword for rubella. Can you tell me when would you see congenital rubella syndrome? So up to 16 weeks you will see congenital varicella syndrome. Okay, can you tell me which viral infection has been linked to Hoff-Bohr cells? Hoff-Bohr cells, which are placental macrophages. So which viral infection? Right, so this is linked to Zika. Right, so this is how Zika virus is transmitted, and I'm sure you remember that Zika virus would also cause microcephaly. Okay, tell me, what about cytomegalovirus? What kind of calcifications? So it will cause SNHL, but apart from that, you will see periventricular calcifications. And you would see again microcephaly. Okay. What about toxo? So toxo, you all know cats. Apart from that, you have to know it causes hydrocephalus and generalized calcifications. Okay, perfect. Now, what is lithium going to do? Jaldi jaldi batana hai. Epstein's anomaly. I think kabhi galat nahi karoge. You are very good at this, right? So Epstein's anomaly, lithium, warfarin, nasal bone hypoplasia. What do we call it? Chondrodysplasia punctata. Okay. Okay, and then one more that we should know is valproate. Kya karta hai? Spina bifida. Another characteristic one, thalidomide. I am sure yaad rakhoge. Phocomelia. And the last one I want to ask you is, what does chloramphenicol do? Jaldi jaldi batana hai. Chloramphenicol. Yes, grey baby. Tetracyclines, they will affect the cartilage. Yes, so they'll cause staining of the teeth as well. Right, so these are the important ones. We cannot cover everything, but yes, we've covered the most important ones which are likely to be asked. Are you ready? Are you with me, everyone? Chalo. Which of the following helps to differentiate imperforate hymen from transverse vaginal septum? Okay, so imperforate hymen, again a topic which is always coming in the exams. So did you do this one right, or you did overthinking? Did you do overthinking? So no, don't do overthinking. Cyclical abdominal pain will be present in both, so you can't differentiate. Primary amenorrhea will be present in both, so you can't differentiate. Yes, hematometra can be again present in both, you cannot differentiate. And therefore, what is the answer? It is A. Why? Because bluish bulging membrane is only seen in imperforate hymen, right? Why? Because in transverse vaginal septum, the block is much higher up. So this septum is located in the upper 1/3 of vagina. And as a result, you don't see the bulging membrane. In fact, you will see a normal vaginal opening. Yes, you will see a normal vaginal opening. Okay, now can you tell me what would be the acute presentation of these two conditions? If they are to present acutely, what would be the presentation? The presentation will be acute urinary retention. But yes, can you tell me acute urinary retention will be more common with which condition? Imperforate hymen or transverse septum? More common with imperforate hymen. Why? Because imperforate hymen is more commonly associated with a big hematocolpos which can compress the bladder outflow. So more common with hematocolpos and therefore imperforate hymen, but can be seen with transverse septum as well. Quickly tell me these things in both these conditions. So whether we talk about imperforate hymen or we talk about transverse vaginal septum, you will quickly answer these questions. What will be the karyotype in these conditions? Jaldi jaldi batana hai beta, because INICET बार-बार karyotype पूछता रहता है, right? So the karyotype in both will be 46XX. What would be the gonad? Absolutely a normal ovary. Because the ovary is normal, they will have normal secondary sexual characters, right? So they will have normal secondary sexual characters. They will have a higher risk of what? Endometriosis. Okay. Now, can you tell me how do you differentiate these two from MRKH? Because in MRKH also, again, the karyotype is 46XX. Again, it is an absolutely normal ovary. Again, they have normal secondary sexual characters. And yes, they can also have endometriosis. But I want to ask you, how will you differentiate these two? Very important. The most important thing. Here the uterus is present, whereas in MRKH the uterus is absent. Okay. A lot of times there is also vaginal agenesis. Last question. Why did I write MRKH can have endometriosis? How come? When no uterus, how endometriosis? So reason assertion question. The reason here will be, yes, this can be explained by coelomic metaplasia theory or presence of ectopic Mullerian tissue, right? Please do not answer this as what? Sampson's theory. MRKH में endometriosis is not explained by Sampson's theory. It is explained by either coelomic metaplasia or presence of ectopic Mullerian tissue. ठीक है? Reason assertion. Chalo. How many of you have done this one correctly? According to WHO guidelines, which of these is the preferred method for cervical cancer screening? And we are talking about poor resource or low resource countries. Yes. So can you tell me what would be the preferred method in low resource? So even when we say low resource, the WHO recommends DNA or HPV DNA testing even in low resource. This is the preferred method because this has the highest sensitivity. Okay. And yes, the screening interval is every 5 years, but it can be extended to 10 years. This is what is the recommendation. What is or what can be done if we are not able to use HPV? Then yes, we can use VIA. So the second preferred method is VIA, which is actually the most cost effective method. So when they ask you most cost effective method, then it is VIA. What is the screening interval? Every 3 yearly. When do you begin screening? So as per the WHO guidelines, you will begin screening at 30 years in low resource countries. Yes. And when do you stop? So not 21. So please understand, 21 is for high resource countries, not low resource. Right? When do you stop screening? You stop screening at 50 years. The recommendation is if you are doing pap smear, it also has to be done 3 yearly, just like VIA. But PAPS is the least sensitive test. Okay, the most sensitive is HPV, then is VIA, then is PAPS. Okay, can you tell me the concept of WHO screening? So it is screen and treat, or we can also say it is screen, triage and treat. So when you do a screen test, it turns out to be positive, you will do the treatment. So you should know these WHO guidelines for cervical cancer screening in low resource countries. Is that clear to everyone? Okay, chalo. Let's go further now. The next question is, your patient complains of malodorous vaginal discharge, right? There is no itching, no dyspareunia. there is a thin homogeneous grayish white discharge, which means you already know we are talking about bacterial vaginosis. Now, the pH is given to us, whiff test is also given. So, almost everything is given. But I am sure some of you have done this question wrong. Can you tell me why? Because do you agree that all these statements A, B, C, D, do you agree that all these statements are true for bacterial vaginosis? So, in bacterial vaginosis, there is no inflammation. This is a true statement, but it is not the answer. Similarly, in bacterial vaginosis, there is no pruritus. This is also a true statement, but it is not the answer. There will be no motile organisms because that is trichomona. So, this is also a true statement. Then why they are not the options? Because you have to read the question carefully. The question says, which of the following must also be present to make the diagnosis using the Amsel's criteria? Do you understand this? Now, if you talk about Amsel's criteria, we need 3 out of 4. Yes, this is used to make a clinical diagnosis. Can you tell me what are the 4 things? Out of 4, 3 are already given to you. So, grey discharge, which is foul smelling, is already given. pH, which is more than 4.5, is already provided to you. A positive whiff test is again already provided. So, what is the 4th component? That's what we are asking. Yes, the 4th component is presence of clue cells, and they have to be at least 20%. Do you now understand why option C is correct? Yes, so at least 20% have to be clue cells. Now, who is going to tell me what exactly is a clue cell? So, a clue cell is a epithelial cell which is studded with bacteria, which means it is carrying the bacteria in a piggyback manner, right? Which bacteria are we talking about? So, we are talking about typically Gardnerella vaginalis, right? So, we are talking about Gardnerella vaginalis. Please remember, the kit that we will give is as per the syndromic management for vaginal discharge, which is going to be kit 2. But if we individually ask you drug of choice, which is an older PYQ, then you will answer it as metronidazole. So, if we ask you drug of choice and you have to mark 1, then it is metro. But if we ask you based on syndromic management, then it is kit 2 or green discharge. Can you tell me which is the kit for PID? The kit is yellow and it is kit 6. And which is the kit for cervicitis? So, kit for cervicitis is kit 1 and it is grey. So, these are very common areas that we ask questions on. So, you have to ensure that you know them. Can you tell me what is the best test for diagnosis of bacterial vaginosis? So, best test for diagnosis of bacterial vaginosis is not Amsel's. Amsel's is a clinical assessment. Clinical assessment is not best. Lab test hota hai best. कौन सा होगा? So, the best test is Nugent score. This is something we see on the Gram stain. Okay, so the best test is actually Gram stain, and a score of 7 to 10 indicates that it is bacterial vaginosis. Yes, good to go everyone? Chalo, let's look at the next question. So, your patient has come to us with lower abdominal pain. She is 35 years of age and her last menstrual period was 2 weeks ago. She is mid-cycle. She is not sexually active. There is a mobile tender cystic mass in her left adnexa. Ultrasound shows a 5 centimeter unilocular thin-walled anechoic cyst. So, now tell me, have you done this correct or wrong? How many of you have done this wrong? So, yes, this is the typical appearance of a follicular cyst. It is the most common ovarian cyst in reproductive age women. And you typically see it as unilocular, which means there are no septae. It is typically thin-walled and it is anechoic, right? Absolutely black, right? So this is a follicular cyst. Do you need to do anything for it? No. So generally we do a wait and watch, right? Most of these will disappear by themselves. So if you do a repeat ultrasound at 6 to 12 weeks, you will realize it is no longer there. Okay, so no treatment is to be given. But yes, if it is a recurrent cyst, then we can give OCPs, right? So if it is a recurrent cyst, then we can give OCPs, because OCPs reduce ovarian cyst formation. That is a non-contraceptive benefit. Now, what is the typical word used to describe hemorrhagic cyst? So if they have to talk about a hemorrhagic cyst in the ovary, we say it is a reticular or a fishnet pattern, right? So the term we will use is reticular or fishnet. What will we say if it is an endometrioma? The endometriomas typically are thick-walled. Okay, they are not thin-walled. And what is the classical description? Ground glass. Or they will say a cyst with homogeneous internal ecos. Okay, so if you see homogeneous internal ecos, ground glass, then that is a endometrioma. When would you say it is a malignant mass or a malignant cyst? If you see solid components, if you see thick septae, if you see papillary excrescences, and if you see increased vascularity, right? So when you see increased vascularity in the solid components or in the septae, right? So increased vascularity in the septae or in the solid components. Is that clear to everyone? Right? So please know you can give metronidazole even in pregnancy for bacterial vaginosis if required. Okay? Abscess कैसे दिखेगा? Please remember, abscess में there again will be internal ecos, but they will be heterogeneous. Will the abscess have increased vascularity or reduced? Again, increased vascularity. What about ovarian torsion? उसमें क्या मिलेगा? Ovarian torsion will typically present with acute pain, maybe like an abscess, but the vascularity will be reduced, right? And you will see a twisted pedicle. So torsions would typically happen when ovaries have large cysts. Then yes, they can undergo torsion. So there the vascularity will be reduced. Okay? Chalo, आगे बढ़े. So which of the following statements about spermatogenesis and sperm maturation is correct? Again, something that the AIMS people are fond of asking. Have you done this? Correct. This is a very elementary question, but I hope you've done it right. So spermatogenesis is completed in epididymis. Is it true? No, it is a false statement. Spermatogenesis is completed in the testes itself. What happens in epididymis? Maturation. The process of spermiogenesis, which happens in the caudal part of the epididymis. Okay. Acrosome is derived from Golgi apparatus. This is the answer. It's a true statement. Mitochondria does not form the head. Head कहाँ से आता है? Nucleus या genetic material. Right? Mitochondria क्या बनाता है? It will form the middle piece. Okay, spermiogenesis involves mitotic division of spermatogonia. No, spermatogonia undergo mitosis. That is true, but that is not spermiogenesis. That is spermatogenesis. Spermiogenesis is only the maturation part. So in spermiogenesis, what is going to happen? These spermatids will convert into spermatozoa, also called as sperms. Chalo, you have to give me the correct sequence very quickly. So the first in the order is spermatogonia. Remember, they are diploid. This will from the primary spermatocyte, which is going to be going to be diploid because it is formed by mitotic division. This will then form two secondary spermatocytes which are haploid. Right? They are haploid because they have undergone meiosis 1. And these will eventually form 2 each spermatid. So a total of 4 spermatids which are not the mature forms and they are also haploid. They will finally undergo spermiogenesis and form the mature sperms or spermatozoa. Right? Spermatozoa. Right? So you should remember the order. Also remember that the gonia are present in the basal compartment of the seminiferous tubules, whereas the spermatocytes and the spermatids are present in the adluminal compartment of the testes. Okay? Chalo. That brings us to the last question and I hope you've done it right. Which of the following statements about estrogen is true? So, estriol is the most potent form of estrogen. Is it true? Absolutely no. It is the weakest. Which is the most potent? It is E2 followed by E1 and then comes estriol. Remember, ethinyl estradiol is the most potent one, but this is synthetic. Okay, whereas these three are natural. Yes? Okay. Estradiol is synthesized in the placenta during pregnancy. So, no, this is not primarily synthesized. It is actually estriol. Right? So, estriol is the predominant estrogen synthesized by the placenta. Can you tell me placenta uses what to make estriol? So, it will use fetal DHEAS. Now, do you all know that DHEAS is what is the biggest production of the fetal adrenal gland? So, fetal adrenal gland सबसे ज़्यादा क्या बनाता है? So, it maximally produces, don't answer cortisol, it is fetal DHEAS. Okay. Aromatase converts androgens to estrogens in the granulosa cells. This is absolutely true. This is the answer. But you have to tell me, where are androgens formed in the ovary? Androgens kahan ban rahe hain? So, androgens are formed in the ovary by the theca cells. And typically, it is the theca interna cells. So, they make androgens. But please remember, ovary will not make dihydrotestosterone and it will not make DHEAS. Okay, it will make androstenedione, it will make testosterone, but not these two. What is the last option? Estrogen is responsible for secretory phase. No, I think this is a kiddish option. All of you know it. Estrogen will be responsible for the proliferative changes, where you will see tall telescope-like glands, whereas it is progesterone which produces secretory changes like subnuclear vacuoles. What else? It will also produce corkscrew glands. And where is this progesterone coming from? So, the progesterone is coming from the corpus luteum. Yes? And who is making the corpus luteum? So, it is made and maintained by LH. Okay, so it is made by LH as well as maintained by luteinizing hormone. So, remember, these are important things. So, when you do an endometrial biopsy, which is typically done on day 26, if you see secretory changes, it means progesterone has come. And this means the cycle is ovulatory. If you see proliferative changes, it means progesterone nahi aaya. It's only estrogen and isliye the cycle is anovulatory. regulatory. Right, so with this we come to an end of today's session. I hope you found it effective revision as well as based on the current pattern of INICET. I have tried to use the predictive topics because it is a predictor test. So how many of you have scored? Okay, I'm going to give you this now. Anybody who has secured 18, 19 or 20 out of 20 will put the fire emoji in the chat box. So quickly, let me see how many you have got fire, fire, fire in your belly. Right? So anybody who has secured 18, 19 or 20 out of 20 will put the fire emoji in the chat box. I am waiting. I have already started to see. Very good. Well done and keep it up. I am so proud of you. Anybody who has got 15, 16 and 17, you have my heart. Okay, well done. And you are almost there. You just need that final push. Okay, so 15, 16, 17, you have my heart for sure. Perfect. So many fires, and I'm sure there are going to be many hearts as well. Okay, anybody who has got 12, 13 and 14. Okay, if you have 12, 13 and 14, I am going to give you a thumbs up. So you are going to send the thumbs up emoji because this means all the best. You are doing good. You're on the right track. You just need to do some more revisions. Okay, and anybody who has secured less than or equal to 11, I am going to sit here and I'm going to buck you up. Come on, come on, come on. You guys can do it as well. I'm sure you are as good as anyone else and you will be there in the list. Okay, so wishing you all the best for your upcoming exams. Throughout this month of April, we will be doing the INICET Predictor series for you live on the DAMS Daily YouTube channel. The test is available free for everyone on the DAMS eMedicoz app on the home page under the daily quiz section. So give the test and then come for the discussion, and I am sure that you will find it very, very effective for your revisions. So all the best. रिविजन करते रहो, आगे बढ़ते रहो और एंड में हम सब चैट में क्या लिखेंगे? अपना टाइम अपन खुद लाएगा. So all the best, dear bachas. May God bless you. Thank you so much for giving me an opportunity to be a part of your journey once again. I hope I am remembered for the right reasons. I hope you hear my voice in the examination hall, and I hope that you do all OG questions correct. Okay, so good wishes and blessings for all of you. Take care everybody. Bye bye. Good night.